Hey there. Hi, this is Elliot Fishman, and welcome to our Facebook Live. Today is the 9th of September. I hope all of you are having a great week. For many of us, it's a shortened week, some shorter than others. Everyone had Labor Day off, not everyone. I, in fact, was working, and many of you were working, but many people had Labor Day off. Not the most typical Labor Day, in the fact that many people did not do as much traveling as they would normally do. And it seems for many people, schools start earlier than ever. So Labor Day is almost after the fact, particularly if you have college age kids, they're all in school already. And even the younger kids have started school depending where you live. In New York, they start this week. In Baltimore, they started 2 weeks ago. So a lot of variation. Weather was good. And those of you who are Jewish, wish you a happy and healthy New Year. So the Jewish New Year was the last 2 days of the year. Again, strange New Year for my life. I've always, since I was a little child, went to synagogue. This year, like last year, I watched the services from home. We watched it at a place called Park Avenue Synagogue, PAS, that had the most wonderful service. It also showed me, not that it's a surprise, that there's some things you could do online that you never would thought would be possible. The fact you're sitting in your living room watching a rabbi speak and a cantor do the prayers, and you feel incredibly touched and connected, in fact more than I might have been if I was in the regular synagogue, says a lot. It also says a lot about technology, how technology has the ability to really connect you, and in some sense connect you even more than if you were in person. So I know I spoke to Steve Rowe today, and he was mentioning him and his wife do church remotely, and in fact that they go more often and they are more engaged. So it's not just me, obviously, and I've spoken to other people, the Zinreichs, very much the same thing. So I think it's a very common thing, which says to me and to you, as we all know, that technology is not necessarily bad. That although you might think technology at times, oh no, it can't replace this or replace that, once you have to do it and you do it well, okay, you can really change how things are done. In fact, I was so engaged that yesterday was the holiday, and I went online and watched services from California and from Florida. Now, it's not often I see three services, but I did, and I think it was impactful. So that moves us perfectly into this week's talk, which is on AI and radiology. And again, some people will say AI, oh, overrated. Some people will say AI is going to replace radiologists. Some people are going to say AI 10 years from now, 20 years from now. Some people will say it began yesterday. I think the way you have to look at AI, and I'll tell you what brought this up. I'm giving a talk of All's Well at the end of October at Kathy Richmond's course, Meg Richmond, to those of you who know her, at UCSD. And one of the talks they gave me is on Radiology 2025, which is really not that far away. Hopefully by 2025, we're going to be out of COVID. Oh my God, we better be. But and when you start looking at Radiology 2025, and I started looking at the changes, it's interesting, but there are many changes that are going to happen, but almost all of the changes, one way or the other, relate to AI. Now, it's interesting, I never claimed to be a great predictor. Remember, I'm the person who 30 years ago or something like that said that 3D would be mainstream, and 3D is better than ever, but it's surely not mainstream. So I'm not the greatest predictor. I also I was told to buy Amazon stock when it was like $10, and I did not think that that bookstore would make it. So much for that, 3,000 or 30,000 times the price a few decades later. But I think one of the things you look at when you start thinking about AI and you start thinking about how to improve radiology, you realize it's all about AI. And I am not talking only about AI in terms of reading the films or helping the radiologist read the films or doing quantification or doing radiomics or doing predictions. The first thing is scheduling. People using AI to do automated scheduling with the patients and to figure out how to do the scheduling in a way that's most efficient. The ability to track patients to different imaging sites. Many groups have multiple sites with multiple scanners. How do you choose the best scanner for the study to be done that works out in the most timely fashion for your patient? Well, AI can do all of that. How do you decide the contrast for the patient? Volume, type, AI can help you with that. When patients are coming to the hospital and the parking is a problem, AI now shows you what garage to go to and what floor to go to and what parking space to go to. So you don't become a wanderer roaming through the parking lot trying to find a space to go. Now you may not think of that as AI, but it is AI because it's simply making decisions and looking at lots of information and in real time making decisions. If somebody pulls off the second floor and you're on the first floor, it'll tell you to go there. If you're on the third floor, it will not tell you to go there because you create a traffic jam and you'd be going the wrong way. When you think about AI, think about the scanning protocols. How was the patient's protocol last time? You need to look it up. That takes time. Maybe you can't find it. Maybe it was some other site you had. Well, guess what? AI can look, decide what the protocol was before, and then you maybe will mark down that was a good quality study and I'll do the protocol again. Or perhaps the AI will see that maybe you gave too much dose last time. It can help you reduce the dose. AI could also help you based on patient's heart rate, patient size, and other factors. Consider the volume of contrast, and then consider the optimal injection rate depending on the patient's size and specifically what you're looking for. In this era where technologists are working in remote sites essentially by themselves and radiologists are doing teleradiology, and often they're working for a group just reading the films but not doing the protocols, well, you're going to need someone to do good protocols. We know that if you don't have good protocols, you're not going to be able to read the studies well. Well, AI could look and say, oh, you want to look for insulinoma of the pancreas. I know that's dual phase. I know it's thin section. I know I better go at 30 seconds and 70 seconds, and I better inject at 5 cc's a second. It also knows I better do post-processing with MPR and 3D, particularly MIP imaging, to be able to look for the small vascular lesions, and we'll do all of that automatically. I think what you're going to see is a lot of the thought process, which is, again, good, but potentially is fraught with error for some people, can be really solved by AI making those decisions. Now, of course, once the study is done, AI can be used to help detect suspected or unsuspected lesions. We're using AI. We're doing our work on pancreatic cancer as well as other pancreatic lesions. But it's not only, and there was an article published in AJR the other week, not only predicting is there a mass present, but looking at a mass and predicting outcome. So is this patient going to survive? Will this patient be better off getting surgery or chemotherapy? Those are things that can be answered. In neuroendocrine tumors, AI can pick up smaller tumors more frequently than radiologists, but also potentially determine the type of tumor and determine whether or not a tumor should be resected when it's small. Will this patient's tumor be a high risk for metastasizing, or will be a tumor that will not metastasize, and so doing nothing will be the best standard of care. We can talk also about, as data gets more sophisticated, if you're looking at a patient with pancreatic cancer, should you give chemotherapy? What type of chemotherapy? How much chemotherapy? What sequence should you do chemotherapy, and what sequence radiation, and what sequence of pancreatic surgery? Can you look not just at that patient, but look at all the patients in your database and maybe in the world's database with that tumor, with that pathology, with those interval changes, with that radiomics, and predict what needs to be done? I think the era of saying there's a 3 centimeter mass is going to disappear. Because yes, a 3 centimeter mass is better than a 5 centimeter mass, and it's worse than a 1 centimeter mass, but size alone may not be the precise criteria for determining outcome. Some tumors are larger, they don't metastasize, and some tumors small metastasize. How often have you or us seen a small pancreatic cancer where you say, yes, early diagnosis, no vessel involvement, no liver, this is a perfect surgical candidate, they get chemo, they get surgery, everything looks good, you say this is going to be a cure, and in the first follow-up, the patient has liver mets or local recurrence. Okay, everything pointed to a long survival, but there was something about that tumor. And I know there's a lot of things going on, liquid biopsies, and a lot of information that's going to be coming out of that to in fact impact what we do. But AI is going to be driving all of those processes. I think right now we have too many silos of information. Radiologists are just too damn busy reading the films. And I don't mean that in a bad way. We are busy. Everybody is looking to recruit. Everybody is short. Everybody is overworked. And the more you read beyond a certain point, your error rate increases, your miss rate increases, and your ability to do a good job decreases. That's just human nature, whether you're in private practice or academics, whether you're in big practice or a small practice. All of these things are the same for everybody. So I think that becomes very important. AI can be that problem solver, that helper for us in making the right decision. I've seen, I mentioned before, we do a speaker series at Hopkins. So one of the speakers, I won't give you his name right now, he'll be until I confirm a date, but he works, he's a brilliant guy, and his current company, he's the CEO of a company called Pearl, which uses AI for dentistry. Can you ever wonder when you go to dentists, we're radiologists, the dentist looks at your images, your x-rays of your teeth for a few seconds that say cavity or no cavity. I always wonder, they look like for 3 seconds. Even I can't read that fast. I know if you have a complaint, then they'll look really hard at the number 12 bite tooth or whatever you want to call it, but it makes no sense to me. How could you do something so quickly? Well, it ends up, when you look at it, if you have 3 dentists and they each look at the same x-ray, you'll have 3 different answers. What he has shown with AI, looking at millions of studies, is that AI is more accurate, it's more reproducible, it picks up more pathology, it guides patient management better. Okay, none of those things probably surprise you, but no one paid attention to AI in dentistry. He has, obviously, and they're going to be incredibly successful because their thing is actually good for the dentist, because the dentist is now more accurate. It also picks up things related to dental health, which might in fact increase revenue to the dentist. Not that they're trying to make more money, but they often weren't doing the right thing by you, and you might have gum disease or some other things going on, which now can be taken care of when it's preventive dentistry rather than when it's a problem with your dentistry. Again, AI is going to change dentistry. When I looked at what he had to show, it seemed to me that you would never go to the dentist again unless they were using AI. That's the secret of AI, if you think about it. If the dentist thinks it's critical and will help him, and the patient believes it's critical, and the patient believes it's going to help the patient, that's the perfect scenario. Now, if you develop an app for medicine, for radiology, on looking at the chest x-rays or chest CTs or liver or pancreas, and the radiologist really doesn't have faith in it, that's going to be a problem. And the patients don't have faith in it, that's going to be a problem. This is not going to work. So I think what I'm learning is from this dental model, and I'm reading a lot more about it, is not a surprise that you need to have all of the various components of the process. The patients, the physicians, the insurers, everyone needs to be paying attention to the process. And when everyone agrees and together says this is the right thing to do, everything comes together, because you have reimbursement, you have better quality of care, you have increased patient satisfaction, increased physician or dentist satisfaction, and better health. So I think that's really going to be big. So I think one of the things you'll see in this talk I'm putting together, I realize the different things. Also, it brings back the point to me that when I ask the question, who's going to be more important in radiology over a number of years, the next decade or 5 years even, Siemens, GE, Philips, Toshiba, they're all going to be important. But the truth is the Microsofts and NVIDIAs and Googles and Facebooks and Apples are going to be more important because they're changing how we practice. Siemens will have better and better scanners, but it's the AI that's going to take advantage of everything Siemens or GE or any of the other companies can do. Now, those companies are not sleeping at the wheel. They are building AI into their products because they know that's really where it needs to go. So let's see. I'll be happy to answer any questions. The only person I see is John Biacchino. John's at home today. Hey, John. John was working the weekend, a busy weekend. I think him and Bill, and they had Pam and the whole old timers, the whole A+ group working for the patients. So that was good. But if anyone has any questions, this is a great time to ask. The talk I give at San Diego will be at San Diego. You got to go to the meeting, but I'm sure that after that meeting I will redo that talk and put it on CTisus. Just to let you know, we are continually building out CTisus on AI. If you go to the website, there is a big AI section which continues to grow. We have an advertisement there from NVIDIA. I put it up there, they didn't ask me to. I think November 8th to 11th, they're having a big meeting, and it's for free, remote and for free. It's a lot of different levels to that meeting, but for beginners, there are special sessions. For medicine, there are special sessions. So I think that's something, even if you're a novice in AI, but you want to learn a lot, they have the best people. The meeting always starts with Jensen Wang giving the state of the art, the state of the world. So that should be exciting. We'll see if Jensen's in person or if it's an avatar like last time is going to do it. But whether it's him or it's avatar, it's going to work. Let's see. When are you doing the talk in San Diego? Is the UCSD, is their cross-sectional imaging meeting? I know I'm speaking on Monday, October 26th maybe. I could be wrong on the date, but it's that last week that they have a meeting that runs a whole week, I think Sunday to Friday or something, and I'm speaking on Monday because I know I'm going to fly in on Sunday. So that's when I'm speaking. So, but you can look online, you can find out. Oh, Meg Fines, who told me the other day, Meg was in New Jersey, used to be at Hopkins for many years, told me she would try to see me at that meeting, and she said it's the 25th of October. So that's the answer. She knows better than me. I kind of know roughly when it is. I just finished up my syllabus because I was updating everything. Even though I did some of the talks I prepared 2 weeks ago, I updated it some more. So I think that part's exciting. So with that, if no one has any other questions, I'll stop there. Thank everybody for their attention, and have a great rest of the week. See you soon.